Today, we will be talking about the details, a deep dive with medical aid and dying navigators. I am so excited for everyone who is with us today to hear what they have to say. We are grateful this webinar is provided by, you're able to have continuing education credits provided by Hawaii Pacific Health and the Hawaii American Nurses Association. And there is a form I have to read. It's required for me to read it for all of you to get the credit. So bear with me. In support of improving patient care, this activity has been planned and implemented by Hawaii Pacific Health and Compassion and Choices, Hawaii American Nurses Association, and NASW Hawaii Chapter. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Hawaii Pacific Health designates this live webinar for a maximum of 1.5 AMA PRA Category 1 credits for physicians. Physicians should only claim credit commensurate with the extent of their participation in the activity. Hawaii Pacific Health designates this live webinar for 1.5 contact hours for nurses. Hawaii Pacific Health is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This activity is accredited for 1.5 contact hours for attendance at the entire CE session. As a jointly accredited organization, Hawaii Pacific Health is approved to offer social work continuing education by the Association of Social Work Boards, approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have the final authority to determine whether an individual course may be accepted for continuing education credit. Hawaii Pacific Health maintains responsibility for this course. Social workers completing this course receive 1.5 continuing education credits. Hawaii Pacific Health is accredited by the American Psychological Association and designates this live activity for 1.5 continuing education credit. Continuing education credits for psychologists are provided through the co-sponsorship of the American Psychological Association Office of Continuing Education in Psychology. Hawaii Pacific Health maintains responsibility for the content of the programs. In order to claim CE credit, please note that in order to receive continuing education credits for this offering, you must claim credit commensurate with the extent of your participation in the activity, complete and submit the evaluation survey that will be emailed to you within 1 week of the offering. Speakers cannot claim credit for their own presentations. Your CE certificate will be immediately available to you upon completion of your evaluation. So let's get started. If you have a question at any time, you can type it into the question box on your screen, and we will get to as many questions as possible at the end of all of the presentations. This webinar is being recorded, but don't worry, we can't see you unless you're presenting. So that you're aware, it is being recorded. Today, we are joined by some amazing humans that I'm very excited to have with us. Susan Amina is a nurse practitioner for Kaiser Permanente. Michelle Cantillo is an RN and is the Advanced Care Planning Coordinator for Hawaii Pacific Health. Jody Shaw is a licensed social worker and works in oncology for Kaiser Permanente. Joy Rodriguez is an end-of-life doula, Burden Lifters LLC, and my name is Samantha Trad. I am the Senior Campaign Director for California and Hawaii for Compassion and Choices. Compassion and Choices improves care, expands options, and empowers everyone to chart their end-of-life journey. We are so honored to be here today with all of you. Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end-of-life journey. Since 1980, we have united over 450,000 supporters nationwide to become the preeminent leader of the end-of-life options movement. We have done a lot of work across the country with all of our partners. As you can see here on this map, Compassionate Choices is probably most well known for passing and implementing medical aid in dying laws. And you can see here, the light blue states are all states that have authorized medical aid in dying. The first one was Oregon back in the 90s. And now there are 10 states in Washington, D.C. A newer trend has been to actually amend some of these aid in dying laws because we found that some of what we thought were safeguards have actually become incredible barriers to patient access, which I'll talk about a little bit later. I wanted to share with you the newest state to authorize medical aid in dying is New Mexico. They authorized, and their law went into effect in June. And their law actually allows advanced practice registered nurses and physician assistants to act as providers in supporting patients to access the option for medical aid in dying. They have a 48-hour waiting period between their two oral requests. So as you'll hear today, there's many steps to accessing medical aid in dying. And one of the steps is a mandatory minimum waiting period. Hawaii has the longest of all of the states that have authorized with 20 days. And as you'll hear about today, it's really a suffering period. And so, in New Mexico now it's only 48 hours because they've learned from all the data from other states. And finally, in most states, you have to have two different doctors confirm a patient's eligibility, which is to be terminally ill with 6 months or less to live, mentally competent of making medical decisions, and to be an adult. Well, these are the same components needed to enroll in hospice. So in New Mexico, you only need one provider if you are also enrolled in hospice. Enrolling in hospice is the second provider, so to speak, which really helps increase hospice enrollment, which we're really excited about. Who is here today? I'd like to ask a poll to hear from you. Who is with us today in our audience? Are you a physician? Are you a registered nurse, an APRN, an LCSW, a social worker, psychologist, a pharmacist, or a pharmacy technician, a student, or other? So let's take a minute to answer our poll. And this will also kind of help us understand how to, who we're talking to make sure we hit all the key points in our presentation today. Looks like almost everyone has voted. Let's wait maybe 20 more seconds. Oh, maybe not. Let's share our results. So the vast majority of you are registered nurses, followed by psychologists. Well, I suppose followed by other, which is very exciting, and psychologists and physicians and APRNs. So thank you so much for joining us today. All right. Today, we will be reviewing the clinical competencies for participating in medical aid in dying. We'll examine the roles of nurses, APRNs, advanced care planning coordinators, and medical aid in dying. They are so incredibly key in this whole process. We'll be examining the team-based approach to patient-centered care, and we'll be discussing the challenges and learnings with implementing medical aid in dying. So where do we start? As a reminder, medical aid in dying is one of many end-of-life options. This is so important to remember. The truth is very few people will actually want medical aid in dying, but it helps people understand that there's a whole range of end-of-life options. So many people want to pursue life-sustaining treatment. Some people want to refuse treatment, discontinuing treatment. Palliative care is wonderful. Voluntarily stopping eating and drinking, called VSED for short, continuous deep sedation, and hospice. And it's really important to note that these options are not mutually exclusive. A person may choose several of these options depending on the stage that they are at. And we always encourage everyone to enroll in hospice. Hawaii has such great hospices. Next slide. Now I'm going to hand it over to Susan Amina to talk about some definitions. Susan, over to you.
Great. Thanks, Sam. Yeah, so we'll start with these definitions. What is Our Care, Our Choice Act? It's actually Hawaii state law, which was effective January 1st, 2019. Gives eligible adults an option to request a prescription that would help them to end their life. We often refer to MAiD, or medical aid in dying, just often is a common term used to describe the practice of implementing the law. Next slide. So looking at this in more detail, it's a medical practice in which a mentally capable adult, so again, this is in our state verified by a appointment either with a psychologist or a licensed clinical social worker or a psychiatrist with a prognosis of 6 months or less to live. That's determined by the attending physician and verified by the consulting physician, and then may request a doctor's prescription for medication which they can choose to self-ingest to peacefully end intolerable terminal suffering. So self-ingest is an important component here. It's got to be self-administered. And we'll talk about some of the challenges with some of our diagnoses. And then really, keep in mind, right, that terminal suffering is as defined by the patient. Next slide. I'm going to pass this on to Jody, and she'll talk a little bit about what the team looks like.
Hi, everybody. Good afternoon. Thanks so much for joining us today. So one of the things we wanted to focus on too for this session was really looking at all the different providers that support these patients and families through the process and even after as well. So for Kaiser, Susan and myself are the two coordinators here that guide the patients and families through the process, as well as supporting the providers, too, through this. At Hawaii Pacific Health, we have the amazing Michelle there as the ACP coordinator and the main one running this program there. Also, they have an oncology social worker, other social workers, and a nurse navigator that participate in the process. And then, as we started to talk about the different providers that are involved in this process, there's the attending physician. For us, it's primarily Dr. Charles Miller that plays that role. The consulting physician, so these are, two of the three required in the mental health provider. The consulting physician is often the specialist that's involved in the patient's care, such as the oncologist, pulmonologist, and then the mental health provider. We, for example, work with several psychologists that play that role for us. And just wanted to note too, for the attending and consulting piece, one of the things that, that Compassion and Choices and all of us are really, in favor of is to have APRNs also fill that role too, especially on the neighbor islands where there are a shortage of physicians that are, in general, and then as well as in participating in this process. So that would just make, more providers available to help these patients through the process. Also involved in the process is the pharmacist. So at Kaiser, we have the patient and our family meet with one of our pharmacists to go over the medication, administration and mixing. We also, connect the patient with our financial services area so that from the very start, the patient and family can be aware of what the cost involved will be. And then definitely a part of the team that is invaluable is, hospice as well. So we always encourage hospice hand in hand with this option. And I would say the majority of our patients have had hospice involved, and we could not do this without them. And then I'm so excited to hear more from Joy today and the end-of-life doulas and, how they can also support patients and families through this process. Next slide, please. So, in general, overall, some of the components of our role as navigators, is to provide non-judgmental support, really providing information in a neutral manner. And, the patient shouldn't be aware of how we feel on the subject. We're there to support the patient and patient choice. And then we walk the patient and family through the process. So coordinating the care, the appointments, helping them with the different forms. And then we definitely, really try to keep in mind the patient's condition and timeline too. So for example, if maybe for a ALS patient, swallowing might be, something of concern and losing that ability. So trying to get them through the process as quickly as possible. We also provide hospice education, referral, and again, partnering with them closely. And even after they're on hospice, staying in connection and communication with hospice, we're accessible for questions and concerns from patients, families, providers, definitely acting as a patient advocate, in helping them through the different steps of the process and with anything else they might need. Providing support to the staff is definitely part of our role. This can be hard for some staff to think about and to accept for patients that they have known, for example, for like some of our patients, we've known them for years. So sometimes it's, supporting staff, but also supporting the providers through the process, especially if this is the first time they're acting as an attending or consulting. And then, debriefing as well is an important piece for our role as well. Next slide, please. Susan, did you want to, or do you want me to? Sorry, Susan, you're on mute.
Can you hear me?
Yes. Oh, sorry, it's on mute again, Susan.
Okay. How about now? I'm having trouble. Okay, can you hear me now?
Yep, we hear you.
Okay, so wanted to talk a little bit in detail around the roles and responsibility of the navigator, which is often very similar, right? Whether it's a nurse or a nurse practitioner at this point, or a social worker. And as Jody had mentioned, right, the focus is really on advocacy for that patient, as well as supporting the family. The goal being that this should be a very smooth process and timely. So we're going to talk a little bit about the first interaction, as well as some subsequent interactions, what's entailed in terms of setting up appointments, the forms that are required from Department of Health, the documentation that we do at Kaiser, as well as follow-up. And again, this process, whether you're at Kaiser or HPH, obviously we're following the state law, but the process may differ a little bit. So we're going to start with talking a little bit about Kaiser's process and how we help patients through this. And we'll often tell patients that even though it appears really complicated and cumbersome, that we're the ones that are going to walk them through it. We'll be the one watching the time frames, and we'll be the one reminding them when things are due. So hopefully it's not a cumbersome, difficult process that's adding more stress onto an already difficult time. Next slide. Yep. So we're going to proceed with our approach, and Jody's going to start us off with the first interaction.
Next slide, please. So for Kaiser, we get the referral from different providers. It's typically the primary care doctor or the specialist, and we receive that referral through Health Connect. And so once Susan and I receive that referral, we take turns on supporting these patients. And the first interaction, ideally it's an office visit and in person. That's the best if possible. So for example, for myself, I'm based right in the oncology clinic, and I can often see a patient right after the oncologist here. And we want to, really sit down with them and then explore in depth why they're considering this option, and really exploring all of the other different supports and options, for example, hospice or palliative care. Are they aware of these things? And then talking about, different support systems and, what is their family support system, and is everyone on board, with this as well? That could become an issue too. We'll cover, do an overview of the law and the time constraints. But again, as Susan was mentioning, really stressing that, we're going to walk you through this step by step. So they don't have to, worry about staying on top of everything. We'll do that for them. They have enough, to think about and consider. So reviewing the process, the first and second verbal request that has 20 days between them, the 3 provider evaluations, the written request form, and then we do a pharmacy teaching visit for them once they pick up their medication after the second verbal request. And we also let them know, as I mentioned, the cost of the medication from the start too. And then again, if there's specific considerations given their condition that we have to keep in mind, we'll try to, I guess, highlight that really from the start. And focusing on could swallowing become a concern, or the ability to self-administer. So really, I guess, bringing that to the forefront if possible at that first visit, so that we can plan accordingly for that. And then we want to definitely look at advanced care planning. Have they done their advanced care directive and post form? Again, the importance of hospice. We'll provide those Department of Health forms to them right at that first visit, and we have a guidebook that we give them. On the last page of the guidebook is a checklist, and that's a really great one that lists all the different steps with dates. And then again, as Susan mentioned, we want to assure them that we're going to help them through this, so that we're following it in a timely manner according to the law. And then supporting not just the patient, but the family, through this process as well. And we do offer to attend when they take the medication, if they want us to be there. Next slide, please. Okay, so I just wanted to share this and just some thoughts on when you're, meeting with the patient, and some things that I try to think of myself, because I think for a lot of us, our days are so busy, and especially, doing this work, it's really a privilege, and I would say it's like a sacred time almost with these patients and families. So these are some things that I've learned from, other social workers, mentors along the way, but really trying to take the time to quiet and center yourself before meeting with the patient and family. I listen to myself, the Calm app, and, it's just music and playing in the background. It really helps me to center, maybe taking some deep breaths, and then really trying to clear your mind and, being open to them so that you can actively listen and be present for them. I think that's such a gift and makes it more meaningful, and helps to build rapport as well. And then again, reassuring them that we're not there to judge in any way. We support whatever they choose. But we also want to make sure they know all the choices and supports that are available to them. But basically, we want to just honor their wishes so they can write, this last chapter of their story as they'd like. Next slide, please. So this is our guidebook, just showing you an example, and it's the cover of our guidebook. Next slide. So for the social worker role, so I'm a navigator and in the oncology social worker position, but for example, at Kaiser, there's so many social workers actually within the system. Kaiser really values what social workers, can do, and what we can do to support patient and family. So, I think we can really play a vital role in the medical aid and dying process, and we can use our special skill set and lens. For example, some of the things that we learn as social workers, starting from where the patient is, trying to focus on strengths and highlighting the strengths. Sometimes patients and families aren't aware of what their strengths are, and they do have them, and just highlighting that. And then, we have the person environment perspective. So really looking at, this person is the product of, of their environment, of their support system and their experiences, and trying to take that all into consideration as we're helping and supporting them. We can help with coordination of care, definitely referrals to different supports, providing supportive counseling. Next slide, please. Advanced care planning, have they done it? Advanced directive imposed, hospice education, and then some other thoughts too, and what maybe social workers can provide. But I have to say too that these are definitely things I'm sure that Susan and Michelle, also do. And but we can also, in our conversations, try to do some life review with them, and and getting to know them and highlighting their life. It can really, bring more positivity and to them, and seeing that their life had meaning. And we don't always have the time to do these things, but if we do, also looking at life closure, and are there any maybe relationships that need to be tended to? Are there folks they want to talk to say goodbye, or that they haven't spoken to in a long time? Legacy work is also something we could possibly do as well, that's very valuable. So looking at things like maybe writing letters, or doing videos for their loved ones. And then focusing too on Ira Byock's 5 tasks of dying. So saying those those words, for example, I'm sorry, I forgive you, thank you, I love you, and goodbye. So those are just some things that we can try to focus on if we have the time to, I have to say, in working with these patients. But I think also the other social workers that are involved in a person's, care for these MAiD patients, they could, they provide, these supports as well. Next slide, please.
Great,
so I'm going to turn it over to Susan.
Thanks, Jody. So actually at Kaiser, how the process starts is typically a provider will identify a patient who's expressed an interest in this option. So they send us a referral. Jody and I pick that up. We initially do an educational appointment to talk a little bit about the process. And if they're interested, then we pick this up and run. The first thing we do is we actually start scheduling appointments. So, we're very fortunate to have an attending physician and a psychologist who will do home visits, which has been really helpful for them to really know the patient and to get a sense of where they're at. So we'll set that up. Typically, it's the attending first, obviously, and then either the mental health provider or the consultant visit next. The consultant typically knows the patient, so we often will do a telephone appointment with COVID, and then, of course, depending upon if they're homebound. We will call them periodically, just as reminder calls in terms of appointments that are coming up or what may be due. After an appointment, we often check in with them to say, hey, how did it go? Any questions? We're really fortunate. We usually get a lot of positive feedback from the appointments with our providers. And then we try to coordinate the second verbal request with submitting a prescription. So how this would work would be the first verbal request would be perhaps with that provider, that physician that they said they're interested in pursuing it. 20 days later is the earliest that they can do the second verbal request. And that's now with the attending physician. If we can do this as quickly as possible, and certainly we try to if death is imminent, we have them submit to us the written request, and that has to be submitted at least 48 hours before the prescription can be written. So we really try to do all of those appointments fairly quickly, get the written request in our hand, and then at the second verbal, not only are they doing the second verbal, but then our attending can then prescribe the medication. And I think for the majority of cases, this goes really very smoothly. For the majority of the cases, patients are actually enrolled in hospice. I can share with you a couple stories, and these are probably certainly outliers, but one of the learnings is we've really reinforced the importance of hospice. And when they are on hospice, checking in on with the patient with their experience and any issues or concerns. There was one I can share with you. There was one gentleman. He was in his 80s, had a history of COPD, and just from the very get-go did not want to enroll in hospice. As much as we talked about the benefit, he was very independent, very much in control in this family. Only the son was aware that he was going through the process. He didn't want his wife to know or anyone else. So very private gentleman. And what had happened was, checking in with him periodically, one day he says to his son, "I'm ready. Like, I'm ready now." So, the son mixes it. And in the process, he says to the son, "Make sure, after I pass away, you call Dr. Miller. Dr. Millers are attending. Even though I've been involved in the case, they have my numbers, they understand my role." He was just adamant to the son, the son was in his 30s probably, to call Dr. Miller. Well, the gentleman passes away. He calls Dr. Miller. Dr. Miller's out of the country. And so without hospice on board, which would have been very convenient for support during and after this event, and they certainly would be coming in to help the patient in terms of the family in terms of calling the mortuary and whatnot. That didn't occur. And so part of it was, not really realizing just how much control this gentleman had over the family, that this man actually stayed in the house for over 24 hours because the son couldn't reach Dr. Miller. Eventually he calls Kaiser. I get in touch, and we go forward from there. But it was pretty traumatic for the son, and it didn't go well. As I say, it wasn't smooth. And so again, hospice can be so helpful in that situation. And then, of course, we're providing family support through the beginning as well as throughout the whole process, and then trying to address family dysfunction, and then encouraging calls with any questions or concerns. And I won't go into great detail on the family dysfunction, but there was one case where it was very difficult with a very cognizant 80-year-old gentleman on the Big Island who had a caretaker, a female caretaker that was his friend for many years, had a son on the mainland who was the POA, didn't agree with what the father wanted to do, although the father had expressed this wish to his primary care provider for several years. And it ended up to be a very difficult situation, despite having telephone conferences with everyone involved. Needless to say, the gentleman passed away in a hospice facility, a residential, so, was not able to take the medication. But just a really challenging case that, again, isn't, I will have to say, isn't the norm. But even just one of those situations can be so very time consuming and difficult for everyone involved. Next slide. So a little bit about once the medication is actually dispensed, again, as Jody had said, there's a pharmacy, a teaching appointment. They go over in detail the medications and the mixing. We do a telephone follow-up soon after just to see if there's been any questions or any concerns. We inform hospice when medications have been dispensed. Jody will share with you in just a bit a story around that. Again, kind of a unique situation. And then we try to do telephone follow-up every few weeks, just kind of based on the patient's condition. And then the other learning that we recently had was periodically reviewing mixing instructions. So I'll let Jody talk a little bit about her story with informing hospice.
Okay. Yeah, these definitely, a lot of these stories, I have to say, they are, like Susan said, they're outliers, but usually it goes very smoothly. And typically we work really closely with the hospices, and, we're in pretty regular contact, and then we all usually know when the patient is planning to take it. And hospice, usually patients want the hospice nurse at least to be there. And some of the hospices, the doctors, they're great, and they'll be there as well too. But I had one case where a lady, a woman, was on hospice for several months, and then she actually reached back out to me. She had been one of our oncology patients and said she was interested in MAiD after being on hospice for a bit. And and I thought that she had at least let the hospice know that she was doing this. And they, the family and her asked me to not really communicate with hospice. And I thought, okay, but at least I'm sure they let them know they started this process, and they're doing this. And then when she was decided to take the medication, she actually did not want the hospice to know. I specifically asked, and she said she's a very private person, and so she just wanted to keep it between her husband and daughter and herself. And she decided to take it one morning very early, and they called the hospice at like 7 a.m. and said, she has passed. She took the MAiD medication, and can you come right now? And so they had to scramble. And but yeah, I mean, it's super unusual, and always best to have everyone on the same page and stay in contact. Okay, thanks.
Thanks, Jody. And then, I did not review mixing instructions periodically, but recently there was a case where this gentleman, they actually had picked up the medication actually in January. He was on active treatment and doing quite well. His last chemo was the end of September. A week later, I get a call from the operator that the wife is trying to reach me. And apparently what had happened was he had decided that he was going to take the MAiD medication the next night. Well, the prior day, he was having quite a bit of pain. So much to my fright, the wife actually gave him like a dime size of the morphine, which comes in a powder for the pain. And then she gives him another dime size an hour later. So she's calling saying he's now unconscious. And so I'm a little bit taken back. Like, so did you realize that morphine was to be mixed with all of the medication? And, she was pretty flustered. Thank goodness she had really lovely neighbors that were with her. But of course, now she wants hospice there. So, I went back just to make sure the pharmacy had talked to her correctly about mixing it. We gave her the correct handouts. And again, it was January, so it was many months later. My concern was that he was going to linger. Like, he died that afternoon, so less than 24 hours. But again, it was just it was a kind of an outlier in terms of, wow, I guess, when someone has got the prescription for that many months, we definitely probably need to start reviewing, when and if you're going to take this, please review the mixing instructions. She, for some reason, she was under the impression that the morphine was not part of the mixture. So again, just an outlier, but you can see how you can easily make assumptions that aren't true. Next slide. And then Jody and I just wanted to talk a little bit about some of our experiences at the end of life at the bedside. So really briefly, I won't go into great detail, but the first one, what we consider a prolonged death is 4 hours or greater. Ideally, a death under 2 hours would be the goal. And this was a gentleman who, he was from Vietnam. I attended the death with Dr. Miller. It was a very small apartment. It was himself, his daughter, and his wife. The daughter's husband was just leaving with 2 young children when we arrived. But to say the least, he actually died. It took over 4 hours. And just how torturous that was. Obviously not for the patient, but for that daughter and the wife. And that was at a time we were using what we call DDMP, which was digoxin, diazepam, morphine, and propranolol. And so since then, our mixture has changed, and we'll talk about that later. But that, and it was changed in part to shorten the deaths across the country. But just that prolonged death is just so very difficult for the family. And again, being there to support them and explaining, that agonal breathing is normal. He's not in any pain. But again, just really difficult for that family. Another experience I had, which was a lovely woman in her 80s. very bright, had gradually deteriorated, was very active, just couldn't do the things she'd want to do any longer, along with the terminal illness. And she was in a facility that was an independent living facility, but it was a religious facility, and they didn't allow her to take MAiD in that facility. So her daughter actually rented a room in a condo hotelish type of building, and she had this beautiful view of the ocean. And as I walked in, she was sitting up, and she was in a beautiful outfit. There were flowers on the table. There was albums open. There was that screen that rotates with different pictures. And really, it was just amazing. Her life, she and her husband years ago had sailed a boat from Tahiti to Hawaii. She was equestrian with horses. I mean, it was really someone that it was like, I would have loved to have known you. I mean, you're just so fascinating. But none did, she was ready. And, she jumped on the bed, looking out the window. Her two daughters were there. I mean, it was just the epitome of gosh, just a really beautiful setting and a really lovely end of life. Interesting, she had a pacemaker, but she chose to take the MAiD medication, and then which would have basically turned off that pacemaker, although she requested, and we had somebody on board from cardiology that soon after actually turned off the pacemaker as well for her. And then lastly, just a crowded room, 53-year-old young man, small man with colon cancer with metastasis to the liver, walked in with Dr. Miller. Actually, I think I came on first. There was family in the hallway. There was employees that he worked with, coworkers. There had to have been 30 people in this small little apartment. He was really uncomfortable with a lot of ascites. So, moving from a chair to the bed, back to the chair, just really kind of an interesting scenario. Thank goodness he actually died within about 15 minutes. But just, the throngs of people saying goodbye to him, and just a little chaotic, trying to just manage this so that, we could make it most comfortable for him. So just kind of really various scenarios. And I think Jody's got a couple of interesting ones to share as well.
Thank you. Yeah, I'll just share these really quickly. I've attended actually one death, and so I wanted to share this. We call it a patient orchestrated ending. So he was a gentleman in his 60s, late 60s or so. He had a head and neck cancer. And so for him, swallowing was becoming an issue. So he knew that it was becoming more difficult. So he let us know, he wants to take it. I think it was like a Wednesday or Thursday night. And he did have hospice on board, Bristol Hospice. And so this is a gentleman that was always very in control of his life. And he orchestrated and controlled every aspect of it till the very end. So he told us, so there was Dr. Beal, one of our oncologists, myself, a nurse and liaison from hospice, to be at his home at 7:00 and no sooner. So we all got there earlier than 7 because we didn't want to be late. And we're waiting outside his door in the rain, waiting for it to be 7 so he could let us in. And then he let us in, and he has 2 sisters, and it was just lovely. It was his night and his show, and he held court, and we reminisced and did life review, and he had words to share for all of us, and it was just just lovely, and he could choose to end and have his final night as he wished. And then the other story is that we had a woman that also had been very in control of her life, and she was so loved and had so many family members from different areas of the country. So family members came in, and it seemed like a week-long celebration of her life. And her husband said that her home, it was so filled with flowers and leis that it was like a flower shop. And she decided to go on her birthday. And was just a celebration of her and who she was. And she requested that Hapa music be playing in the background as she took the medication. And she just planned every detail. And so it's so amazing that we can, help patients to have this choice so that they can have these endings, as they wish. Okay, thank you. Next slide, please.
So just a little bit about challenges. So one of them, I think, and Sam had referred to this, is if we get late referrals from providers or we're aware of patients that are actually very ill, we've had many patients die before they can complete that process. And so that's really, it's very sad in the sense that this is not the ending that they want because of that 20-day waiting period. So we're hoping over time with some legislative changes, this can be narrowed. But, this happens when we get patients who are so very ill that they can't actually make it through the process and we can't meet their wishes. Certainly family dysfunction, again, not common. I can say the majority of the time, I've had many family members say, I don't necessarily agree with this decision, but I'm going to support my mother or I'm going to support my father, which is really, they're really being the ultimate advocate because this is not something that they necessarily agree with. I would say many times that's a scenario that we run into. Lack of communication between family members, which I think Jody will address in just a bit. Obtaining a consulting physician when prognosis is questionable. So this is the case that came up with that woman with heart failure and the pacemaker, is that the cardiologist really felt comfortable being the consultant, but really wanted that patient to have, I'm sorry, actually, I take that back. It was a different case. This was a gentleman with heart failure. Cardiologist wanted him to have an angiogram and he declined. And so again, it's just, it's certainly the physician's choice whether they want to be involved in terms of being a consultant, but it was a little bit challenging just because there weren't a lot of other providers involved in his care. This situation worked out okay, but again, that's been a challenge in a couple cases in terms of finding a consulting physician. Certainly provider access on the neighbor islands is an issue, certainly not for so much for Kaiser, but I know for other healthcare providers and organizations. Limited patient resources in terms of location to take the medication and someone to mix the medication. We can't mix it ourselves. Hospice doesn't mix it. So it's really finding someone that's willing to mix it for that patient. I think Jody will talk a little bit about that as well. Patient's functional status. So again, this medication can be administered rectally. That's not something we've done yet. It's all been orally, but I've had several patients with dysphagia and ALS that they made the decision to take the medication when they did because of progressive swallowing difficulties. And then always when meds expire, because we've had patients that have lived beyond 6 months, you certainly need a workflow there in terms of is the patient reevaluated or how do you proceed from there? Jody, I didn't know if you wanted to talk a little bit about the issue with the family communication or the limited patient resources.
I'll say it really fast and then we can hand over to Michelle. So in one case, I had been dealing mostly with the daughter, and all our conversations were through the daughter per patient request. But then the husband jumped in at the end, and he was filling a lot of the roles, and I don't think they really talked completely. So there was just some confusion there. So that's something maybe to really we can focus on or make sure we're aware of for future cases. And then in another case, as far as resources, a patient lived in an assisted living home, and he didn't have any family here. So there was actually someone that he actually helps patients to fill this role of, maybe doing the teaching and helping with the medication. So there are different resources, and I know there's end-of-life doulas as well. But thank you. Thank you. So sorry, Michelle, go ahead.
Thank you. Thank you, Susan. Thank you, Jody, for sharing your patient stories. We learn so much every time I listen to both of you. So thank you for your wisdom and being your patient advocate. So thank you. I'm going to share my experience as advanced care planner coordinator in my role at Hawaii Pacific Health. Next slide. So before we start with medical aid in dying, I want you to focus on yourself. What is your moral compass about medical aid in dying? So very important. I can tell you as a new grad nurse, way back 30 years ago, my moral compass had to do when I was working for agency, when I first started nursing in Toronto. And they said, Michelle, do you want to go to an abortion clinic? And I was like, oh dear, new nurse, this is not what I expected, but very ethical, a lot of complexities regarding abortion back in the 80s, also early. So I did. I worked with them. I did through agency for about 8 weeks, actually. And at the end of that time, I felt really satisfied and peaceful because I was able to help patients as young as 9 years old and their family and their support. So, and I was okay with that at that time. Same thing with medical aid and dying. Touch in. What is your moral compass? Again, like Jody had said, we're not here to pass any judgment. Our goal is to support you and your journey through this and help your loved ones as well. So I applaud you guys here today because you are educating yourself about the requirements of the law, because there's so many different processes. And Sam, thanks for the great update about New Mexico. That's amazing. And we will continue this journey with the legislation. Know who your resources. Yes, Kaiser has a great system and they have their staff, and HPH has their processes and things like that. As an independent person, physician or psychologist or social worker working with one doctor, so know who your resources, who are your physician champions, right? Who can you go to for help? And it doesn't have to be, again, within your system, outside of your system. Nurse practitioners are my champions as well, because they can help provide that. They're also, like Susan is, the navigator. I work a lot with our oncology nurse navigators and our social workers. And again, not the social workers only on oncology, all the social workers in the inpatient, outpatient have been educated on this process. So they'll email us and say, hey, we got a patient requesting inpatient, they're interested. So then we have to follow up on this charge. Obviously the hospices, and then a little bit more, I'll talk about the end of life doulas. And Joy is going to speak on that. Community resources. I've had to call on Compassionate Choices many times when it's like, I couldn't get a consulting physician. I need backup, So rely on those people as well. Recently, I also talked to the physician in Big Island because I needed some help and support and questions because we had our first Big Island patient. So know who they are. Call us too. The last point I want to make is who's your backup? So whenever you create a system, whether in your small independent office, a clinic, an organization, when you go on vacation, who's your backup? So I know all of the above people are my backup. So make sure you create a system, like Dr. Miller, when he went on vacation, who's his backup, right? So that was, to wait for 24 hours with the patient, that's tough. So always create something in the process. Who's your backup? Next slide, please. Every time I work with any patients and their families about medical aid and dying, and this is not only for medical aid and dying, it's for all your patients, right? Your role is to listen. And that's why I really love our social workers, because they do this so well. And pay attention. They know you're like Jody say, have that sacred space. What is your intention as you go into? Hold no judgment. Listen, and then you can reflect. By listening and reflecting with the patients and or their family or loved ones, you can help clarify their confusion, what's going on with their communication. And always with these patients, I say, okay, summarize. What's our next steps? What's your homework? What do you have to do? What do I have to do? And then, of course, share your experience, any things, and update your team as well. Next slide, please. Part of medical aid in dying of patients with serious illness is really a goals of care discussion. Really, before we jump to step, getting the prescription, getting all the requests, understand the patient. So these are just some points for you to kind of go through. What's your understanding? I really love talking about their fears and their worries, because some of them says, yes, I'm at peace, but sometimes they're like, I'm so worried about my child, or, you know, my grandchild who I'm living with. We had a patient who wanted to take medical aid in dying, but so close to their teenager grandchild, you know, about this. So it's very important to talk about it. The spiritual and religious needs, you know, what is their next steps in their journey? And then before I get to the question of, and I do ask that question, why did you choose medical aid in dying? And their reasons could be varied. I don't want to be a burden to my family. I want this end of life option, you know, very varied. I want that control. I want to be in peace. So I also ask them, what's your timeline? Is this urgent? Is it down the road? Are we starting the process? It's just education. So I want to get a feel of where they are and how fast do we have to get the medication, you know, post the second oral visit. And like I mentioned before, reviewing the next steps with the patient. Next slide. Other discussion. Definitely your support system. Who's there? Some people have, like Jody had mentioned, sometimes they don't have anybody. So that's important to figure out ahead of time. Advanced care planning, such as pulse, very important that, you know, we don't want 911 to be called accidentally. There's no pulse involved and patient has to go to the hospital. So very important to get the ACP done. Definitely their functional status, their swallowing, etc. Hospice. Shout out to the hospices. They're awesome. Whether the policy is to be at the bedside or just outside the door, off the premises, they're all beautiful and they've worked well with all of our patients. Education, like Susan mentioned, double check with them, the mixing of medications. With the mixing of medications, I actually don't encourage the patient to do it because I focus and say, this is your day. I want you to think of you're in control, but I want somebody else to participate to help you. And that's that's okay. That's legal to get a friend, a family, somebody to help with mixing. They don't have to worry about that, because at that day, you know, anxieties are high for families and even patients and things like that. It's not every day that we die, right? And payment. People always ask about the cost, right? The cost for even the physician visits, which are covered, and the cost for the medication, which I'll go through later, but out-of-pocket expense, insurance, and MedQuest. Next slide. So this is some feedback I have received from some patients. So this is a patient who's going through the process, and I will read it out because I think it's very important for your role, what you have to do. It was such a helpful info and not as scary as I thought it would be. The major difference is how easy it is to talk to you about a difficult subject. Remember, they're coming to you, right? So you answered so many questions I had not even thought of as yet. And so there are subjects I won't have to worry about. You have prepared me with the needed information. I'm so glad you're not a patient going through the process. I'm glad you and your social worker are still willing to work with me, even though I'm getting my cancer treatments elsewhere. You two are such important people on my team, and I'm willing to navigate this, to help me navigate this new and challenging process. And that's so important because that patient was scared. Oh my gosh, I'm going to get my cancer treatment, get a second opinion, and get my treatment elsewhere. And then she was scared to access, will you still continue my medical aid in dying process? And we're like, absolutely. Our oncologist was like, yes, of course. And we support her. And she has her medication. And then one was this is from a patient's spouse who did pass away naturally, didn't take the medical aid in dying because he had a function, he was declining fast. Even though he didn't ever taken the medication, I'm so glad I went through the process with him, even though I didn't want to. It was so helpful to have someone who I went through the experience to talk with. Now I want to play that forward. And if you ever need me to speak with another spouse and family, I can do the same. So basically that patient was outer island, and I had another resource because she's like, I just want to talk with somebody who's been there at the bedside, because honestly, I have not been at the bedside. And so I was able to hook her up with another patient support who had said to me, Michelle, if you need anybody, I'm willing to talk to patient's family and patients as well. Next slide. Some of the challenges, much like how Jody and Susan mentioned, at Hawaii Pacific Health, we have had 9 unique physicians write the prescription. We have a baby under 15 physicians who have said, yes, I will do the prescription, be the attending physician. But many of them, especially the PCPs, will say, I'm only going to do it if it's my patient. They won't go outside their box and say a new patient to get some consultant. Some do, but the majority of PCPs don't. So then I would have to search out and look for other physicians, sometimes outside of HPH. Department of Health paperwork, it's a lot of paperwork. And sometimes because we have a lot of patients going through this process, we sometimes 6 months down the road and we have to write the Department of Health when you do your prescription. Sometimes we do forget, human brain. So we have a log and we have to remind each other and our team because we have forgotten. We try to get that done within the 30 days, but sometimes we fail a little bit, not too much, but sometimes we just, oh no. Transfer service, the last patient I told you about, yes, we'll absolutely continue if you want to do medical aid in dying, regardless of where you're getting your treatment elsewhere, total okay with us. Declining of patient health, we already went through a lot. We had a patient with ALS, with dysphagia, and he knew for him, it was once his swallow, when I interviewed him, we talked for a whole hour, but he says, Michelle, it really takes me a strength to hold my head up. And then with the swallowing, he says, when I lose my ability to swallow, this is when I need to take my medication. He was already enrolled in hospice. And he says, it takes me 2 to 3 hours to really chew a small, simple meal. And then capacities, we had a lot of patients who have started a process and could no longer go through because of their declining their health and their capacity. Some of the patients we've had, and a lot beginning in 2019, when they just rushed, the patient wanted it quickly. The family came in and they wanted it now. And then we have to slow down that process a little bit and make sure and really educate them. We got palliative care involved to really go through and work with the family. There was another oncology patient who had started the process, and then he's like, oh, wait, I want to wait. And then it was a couple months. And then in the last minute, he's like, okay, I'm ready. Just like Susan's patient, he was ready. So basically, and I want to do it today. And we were like, oh dear. So we delayed getting the medication right away because he wanted to wait. So basically what I had to do, I live in Kailua. I went down to Straub, get the medication from the oncologist, took it over to the RX in Kailua, dropped it off. And then within an hour, I got the call and got the pharmacy ready, got the patient's family ready. And then within an hour, I got the call, patient expired. So 2 different stories there. And then we went through already uncertainty about MAiD, make sure to keep the communication lines open with all, no judgment there. Late enrollment or hospices, we try to get them, if they're oncology patients, with the concurring care, the supportive care early. Some people says, I don't want to use my benefit, so make sure, I don't, I think we have to leave that up to the hospice liaison because they know best. So, but get them on board, at least let them do, that's their homework for us on their side. Medication, prescriptions. The delays I'm talking about is sometimes with our outer island patients. We have to FedEx it over, and it takes another 24 hours. And also, one of our oncologists works part-time, and so the Kauai patient was ready for its prescription, but then our oncologist was not coming back for the next 5 days. Thankfully, it was not urgent. He just wanted to have that comfort of having it, so he was able to wait. And then when we have people who says, I have nobody to help, the wives and the support people says, oh my gosh, I don't know if I can mix up medication when it's time. So what we do at that time for those patients, we call the end-of-life doula. We call burden lifters, not like Ghostbusters, but we call burden lifters. So I'm going to introduce Joy for us to go through what the end-of-life doula does. Next slide, please. So with Joy, we have had 8 patients that we have consulted with her for medical aid in dying. 3 of those patients have passed away with medical aid in dying with Joy at their bedside. And Joy, you could take it away from here.
Thank you, Michelle. Thank you very much for the wonderful introduction. Yeah, called Burden Lifter. And also thank you to Sam and Susan and Jody. And so as Michelle was saying, that when a patient is interested, sometimes I use the word client because I'm a non-medical provider. Sometimes when the patient goes down this medical aid in dying journey, they're usually resolute. However, their primary caregiver often, as Susan and Jody implied, are a bit more cautious. And it's very helpful to have someone who is non-medical that they can talk to and that they can have support even outside of the limited timeframes that you guys have because of your high patient load. And it's also nice to have an education for all of the ohana, not just the patient and their primary caregiver. In that, having an end-of-life doula on board is very helpful because the patient and the primary caregiver no longer bear the burden of pass that off to the end-of-life doula. And as they had past said, one of the many problems of the medical aid in dying or fears is mixing the medication. An end-of-life doula can do that for the family. And then they don't have to worry. They can hold their space sacred. They can stay present in the moment, and they don't have to have that as one of the things for their concern. Further, HPH and Kaiser, as we know, have wonderful, awesome coordinators and navigators and a huge support system. But if your patient is with a private provider or outside of those two systems, sometimes it's difficult for them to find the services and coordinate their care. An end-of-life doula can serve as that coordinator, and Compassion in Choices does offer a referral service also. So for those attending physician, consulting physician, and psychiatrist that needs to be in attendance, those 3 providers. Also, the logistical support and coordination with the points of contact includes what we were just talking about. And then also for a pre-ingestion meeting with the care team, it's usually really nice to have an end-of-life doula involved for the medication pickup, for other logistical support, and also to just go over everything before your ingestion date for that extended family and the rest of the care team. End-of-life doulas also help with life review and legacy projects, similar to the roles played by Kaiser and by HPH. I've had some really wonderful talk story experiences and just a fantastic time. Also had many check-ins that were great. I had one of my patients has written a comic book in which he, of course, is the main comic book hero. But I do get to be a supporting comic book character. So those legacy review projects are really kind of great. And once again, end-of-life doulas are valuable because they're non-medical 24/7 emotional support for the patients and their loved ones. This is especially important right before the planned ingestion date. that phone call or in-person visit the night before. Is everything in order? Are all our ducks in a row? Are all our I's dotted and T's crossed? Having someone to talk to connect with, to reassure, it lifts a big burden from the shoulders of that primary caregiver and the patient. We end-of-life doulas also help with the event planning and bedside attendance. We do serve as visual assistants, both pre and post-death, and are involved in celebration of life, both prior to and the day of death. I'd like to bring your attention to the quote there. That's from one of my former clients. Her husband did take the the death hastening medication, and she was a very cautious caregiver. She was very concerned that this background. But we had many meetings together. We had 3 in-person meetings with her and her husband, with her husband, her children, with her and her husband, and several phone calls. And then at the day of ingestion, she was very comfortable with the process. She knew what to expect. She was right in her heart. And I'm seeing that my Wi-Fi is unstable and I am frozen. Are you able to hear me now? No.
Oh,
Yes,
that's better. It's a lot better, Joy. Thanks.
Oh, I don't know what I did, but that's wonderful. Good. Okay. So, yes, so she by the time that she was done with the medical aid in dying journey with her husband, she felt that she also was able to share her experience with others and is willing to mentor other spouses who are walking down that journey. Okay, next slide, please.
So we're going to talk about 2 stories. I know we have 15 minutes left, but the first story, and both Joy was present. The first story is Judy, and I've talked about Judy many times before. I'm not going to share my side. You've already heard that, but for those of you who haven't, she's 76-year-old, and she had a metastatic breast cancer. She was an independent living facility, and she had wanted us to do our homework for medical aid in dying way back in 2018 with her PCPs and her palliative care physician. So she had us do a lot of homework before working with the independent facility, etc. And her attending physician was Dr. Dawn Manai, geriatric palliative care. And Dr. Manai had written her first medical aid in dying prescription for us at HPH back in 2019. And after that, she had a little struggle after she did write the prescription for the patient. That patient, by the way, never ended up taking it because she had declined fast. But she kind of put a hold on medical aid in dying. So, but when Judy, 8 months later, came 2019, October, said, you know, Dr. Manai, I want to really, I'm ready to engage and do the first over request. For Dr. Manai, she's like, I know Judy so well. We have such a beautiful relationship together. There's no way I cannot help her. And so she did agree to be her attending physician. And at that time, Joy and I encouraged her because Joy was, I encouraged her to be present at the patient's bedside. And so Dr. Manai wanted somebody to hold her hands, and she's like, Michelle, can you come with me? And at that time I couldn't. And she did ask Joy to participate. So I want Joy to please share your side of the story, what happened on that day. And this was in March 2020 during COVID.
Yes, and so this was at the very beginning of the legal time for Hawaii with the medical aid in dying. And I had come from Washington State, so had experience with end-of-life Washington in the past. So first, before the day of death, let's back up to the pre-meeting, which Michelle coordinated, where we had the team from HPH, we had the team from the hospice, we had the team from the assisted living, we had her primary caregiver, we had her end of life doula that she had hired. And I was there. It was a full house, and this was just the pre-meeting. We got out the medications, which I think in the pre-meeting is really important because there's curiosity involved from all of us. And also just the logistical side of things. And in this case, that was a good solve because we saw that back then they were prescribing D-DMA. And so there were two containers, and one of them was really tiny and it had just a few grains in it. And so the practicality of the mixing became complex. And because of that pre-meeting, now at this point and this point forward, they switched to DDMA and now they do DDMA PH. So that was really helpful, the tactile experience. And then on the day of, it was like Michelle has told you in the past, a very, very crowded room. And there wasn't very many people with the experience of medical aid in dying at that point, even though we did have people from the hospice team there. We had people from the assisted living facility there. And we had I think we had some HPH people, plus her large Ohana group and her end-of-life doula and Dr. Manai and myself. And so there were so many people there that during COVID, we had to have two different rooms and we would sub out with each other. But since I was there for reassurance and support for Dr. Manai, she then brought her along to an acceptance. I mean, Judy's death was so beautiful that it really brought Dr. Manai along to an acceptance that assisting with MAiD and serving as an attending physician or a consulting physician was really very valuable. And so she's now an active participant and a valuable member of our MAiD community. And I feel very grateful to her that she allowed that to happen. And it was useful for the comfort of her Ohana, of Judy's Ohana, and for the whole care team to have a end-of-life doula there involved. The second patient story that Michelle and I wanted to, we're back. The second patient story that Michelle and I wanted to talk about was a dentist with Parkinson's, and he had a planned day of ingestion. He'd been supported by Michelle and the HPH team. And then on day of ingestion, they decided that they needed someone there to mix the meds. And so they brought me in. This guy was a live hard, work hard, play hard type of guy. And he had his buddies that he did his motocross with. He had his hard time paddlers, and he was going to go out the same way. So they had busted open bottles of Don Julio 1942. They were talking stories and they were singing songs. In fact, this individual with Parkinson's, who was down to 1 and 2 word sentences, busted out the full rendition of the Beverly Hillbillies, and it was quite something to hear. But he took his pre-meds, and then the time passed, and it was time for ingestion. And so I asked him whether he was ready to proceed, and he looked around at all of his friends and family, and he said no. And so it was nice to have and I feel grateful that I was there, because we just said that's fine, no problem. And so they continued their party for a little bit, and then the party broke up. We contacted HPH, and Michelle helped to get the pre-meds refilled. I brought him back to the house, and he waited another 3 weeks before he was ready to ingest his medication. And then when he ingested on that day, it was a completely different story. He was alone in the room with his wife and his daughter, and it was a very sacred, quiet, calm time. So it's really, the medical aid in dying allows the patient to have the death they choose, even if they're not even sure that the one they wanted isn't quite what they wanted. So that is our other story.
Thank you, Joy. And we were so relieved to have Joy there with that second story. Because can you imagine if a patient's family had gone ahead and mixed up that medication earlier, just right after the pre-meds? I mean, yes, we would write another prescription and do the cost again, but I was thankful to having Joy with that patient. And so was the wife. She was so appreciative. So I know we're running out of time. So quick, next slide. We're going to go through the medication. Just to FYI, the pharmacy, Kaiser has their pharmacy that helps them. And Susan will talk about that in a minute. But we do have Elex RX. The pharmacists over there are awesome. If the patient needs more education, they'll do it with the patient. They'll do all the paperwork that's necessary and consult them, etc. Next slide. So these are the medications currently that Kaiser, and we'll talk about what we do in the HPH. So Susan, you want to explain to them about DDMA?
Sure. So DDMA is the regimen that we use. We do, like all of their regimens, do anti-nausea medications an hour before. The DDMA, obviously high doses of digoxin, diazepam, morphine, and amitriptyline. The goal being death less than 2 hours is the goal. And as I say, we've gone anywhere from, with this regimen, from 15 minutes to about 2 hours. I think there is some benefit to adding phenobarbital, which I think they do at HPH, which we've yet to do.
Yeah, so the DDMA-PH with the phenobarbital was added on this year. And basically, American Clinical Academy for Medical Aid and Dying, that was created last year in Berkeley. They have created a beautiful, and go on their website, they have a lot of information and resources. And they are a team of doctors that's kind of doing their own research on adding the phenobarbital, because they've had with the DDMA patients who have 4 to 5 hours, outliers. And their goal is to reduce that time, as for patients and their families. So when they added the phenobarbital, they found they decreased that time of death an hour. So the patients were, dying versus the DDMA and the DMA, 2 hours, the DMA, and then an hour for the DMA-PH. And the cost really for the extra is maybe $50 more, honestly. So, and the Elex RX does do that. And so we've had a couple patients, and patients have expired less than an hour with that. Next slide, please. Susan, you could talk about the red flags, please.
Sure. So really briefly, obviously, if there's any GI absorption issues, we take a look at the chart for some of these issues just to see if this might be a red flag for a prolonged death. Tense ascites, certainly we see with liver cancer, and they recommend paracentesis, the day prior. Cardiovascular wellness, especially in younger patients, and that's even if they've done like remote extreme, an extreme athlete that's been many, many years ago, that may be, they may resist these medications. Obesity, typically over 300 pounds, again, primarily affecting the diazepam in terms of it being a lipophilic drug, which is going to be absorbed more in the adipose tissue than in the bloodstream. Alcoholism, you're talking a lot of alcohol that's going to be resistant to the sedatives, a fifth of liquor a day or like a case of beer a day. And then tolerance to opioids or benzodiazepines, which actually I think it's phenobarbital actually may be helpful in that case in terms of decreasing time to death. Next slide.
This is basically a lot of coordinations that I mentioned, but the pharmacy getting the hard facts, the mixing and medication, and really education about the safekeeping of the drug. Make sure they know where it is, when to find it. Medication disposal, take back program. Long's Drugstore has a take back program, the police department. So I usually email patients' families after if the patient never took it and tell them where exactly to take it back. So you can go on the web and things like that. Next slide. Next. So on the next.
We only have 5 minutes left, so we're skipping ahead.
Yep.
Michelle.
Go ahead, Susan.
Sure.
Oh, you're on mute, Susan.
Sorry, I think we've talked about this already in great detail. You know, hospice is vital. We work closely with all of the hospices. Again, office or face-to-face are so much more fruitful than telephone visits, but with COVID, that's kind of where we're at. Home visits have been really valuable from the patient and the provider's perspective. Patients have really appreciated the option to have navigators and physician and doulas at the bedside at the time of ingestion. Navigators are certainly in a position to assist family members to process. Again, recent learning of reviewing mixing instructions periodically. We do have a tracking system that helps us to adhere to the law and the timeframes, and then just open communication with support person. We spend a lot of time with families, helping them deal with not wanting their loved one to die, but at the same time, not wanting them to suffer.